Well, I'd like to thank Kate for such very kind words and James for inviting me and for all of you giving up your evening to come and listen. I think I'm most nervous of my son, who's in his first year at university, who's sitting in front of me, and I will try my best to keep him interested. He's a geographer. Right, what am I going to talk about? Well, as Kate says, I have two hats. I'm a scientist, so my office is down the road in this very nice, very nice building. I don't think I'll try that. And we obviously do, we have the scientific aspect. But as Kate mentioned, I'm also a clinician, and I see children in clinic and have retained the kind of work I do in clinical practice. So what am I going to cover this evening? I'm going to talk about ADHD, and I'm going to focus on two things. What is it? What have we learnt about causes? And ADHD, I think, is something that attracts myths, misunderstandings, and I think, we can have lots of discussion and debate, but actually what I want to do this evening is bring some of the science and some of the evidence, so we're not just dealing with myth, we're actually dealing with evidence. So let me begin with, what is ADHD? The first thing people say to me is, oh, you work on ADHD, that's something new, that didn't used to be around in the olden days. Is it new? Well, no, actually, for those of you who are historians, a Scottish physician called Alexander Crichton, Sir Alexander Crichton, he became, first described ADHD in 1798. Sir George Still, who's famous as one of the British forefathers of paediatrics, published descriptions of ADHD in the Lancet back in 1902. Later on in the 20th century, the Americans, of course, have their own classification, something different. They coined the term attention deficit disorder, ADD. So you might still hear this being talked about, ADD. This was later changed to the American diagnostic term of attention deficit hyperactivity disorder, ADHD. And for a variety of reasons, more people are familiar with the American term than the term used by the International Classification of Diseases, which is the one that we use in the UK and the rest of Europe, where ADHD is referred to as hyperkinetic disorder. Just to say that ADHD and hyperkinetic disorder are broadly similar, but hyperkinetic disorder is a little stricter than the American ADHD. So it's not new. So what are the clinical features? So this is the International Classification of Diseases. Well, ADHD, by definition, it's a developmental disorder. The onset is in early childhood. So is it just like high-spirited children? No, we're talking about very, very severe problems with inattention, not being able to concentrate, motor, what we call motor, overactive, restlessness, fidgetiness, and very marked impulsiveness, beyond what you would expect for the child's developmental age. Just to give you an indication that this isn't just high-spirited childhood behaviour, that these problems aren't just there at home, they're across different settings. So they're causing problems in school if for children, in play settings, in other people's houses, and for adults, the work setting. And then this comes to the final diagnostic item. You can't just have the symptoms, they've got to be having a significant impact, getting in the way of learning, getting in the way of friendships, making friends. So we're not just talking about just an extreme sort of child personality. So the other thing that people often ask me is say, well, you've given me the symptoms, but what about a test? Is there a test? Unfortunately, there are none. There isn't a blood test, or a gene test, or an X-ray, or a brain scan. Now, brain scan studies have shown that the children with ADHD, the brains do look different and develop differently, but it isn't a sort of what we would call a reliable marker where you can use it for a test. So basically, you're reliant on a careful, clinical, diagnostic assessment. Is ADHD alone in that? Is that why it attracts so much controversy? Well, no, actually it's true for quite a lot of other brain problems. Autism is another one where there isn't just one test. Adult psychiatric disorders. Migraine is another one. The brain is complicated and it's not everything as yet that we just have tests for, so you do need a careful assessment. The other thing people say to me, and I've got 2 sons, so I kind of get what they're saying, but I hope I've explained that this isn't just normal childhood. Doesn't everyone have a bit of ADHD? And the reason people think this is because what they see is, like so many other things in life, height. You've got some people, like myself, who are at the lower end, and some people who are very tall. You've got blood pressure. Some people have got very low, the majority in the middle. And then you've got high blood pressure. And here we have a threshold beyond which we call it hypertension. Blood sugar, diabetes. We've all got blood sugar. When you start getting high levels, we call that diabetes. And there's a bit of a fuzzy boundary. In fact, the point at which we treat is different from when I was a medical student, rather a long time ago. So ADHD, to some extent, is like that. That's why it seems like, well, doesn't everyone have a bit of it? Yes, well, perhaps to some extent, but we're all here, and we're talking about this group at the end. The other thing that we know is that a lot of people say, well, actually, it's really funny, but Joe has got ADHD, his brother's got dyslexia, and he does seem to have quite a lot in common with the neighbour, his child, who's got autism. Well, we now know that actually all these, what we call developmental disorders, do show a lot of overlap. Communication disorders, language disorders, autistic spectrum disorders, specific learning disorders like dyslexia, tics, ADHD, intellectual disability. There's a lot of clinical overlap. People can have combinations of them or features of them. And we also, I'm going to tell you a little bit about, we now know that there's actually the same sets of risk factors that cause these problems. The other thing I get asked about is ADHD. Is it a Western disorder? You know, it's just, you know, it's not there in other countries. It's there in, of course, it's really bad in America. Britain's pretty bad. It's not there anywhere else. Well, actually, there's been lots of studies. And while the rates differ a little bit depending on what instruments and diagnostic criteria used, it's been found in all countries. What I do want to point out, though, because, of course, the impact of it, the impact of any disorder, is going to depend on context. If you've got a child who's not, you know, if you've got a very flexible social, educational and work context, the impact will not be the same as where you've got a very, very strict, rigid context. So the impact might be different in different places, and over time, but actually the disorder is found everywhere. We also know that ADHD, like autism, learning disorders, all these developmental disorders, for some reason boys are affected. For some reason the male brains, especially early on, are more vulnerable. The other thing I get asked is the rate of ADHD is rising. That proves it's a new disorder. Don't care about Alexander Crichton. It must be. Well, actually these are UK figures. Yeah? If you take the very narrow international classification diseases, the rate's about 1.4 children in 100 are affected. Take the American diagnosis of ADHD, about 3 in 100. These are UK population survey figures taken from very recently. They were exactly the same in the 1980s. So the rate in when you look at population surveys hasn't changed. But what we do know, of course, is that the rates of treatment have gone up hugely. The rates of recognition and referral have gone up. And that's partly perhaps due to increased awareness, perhaps changes in the context, so the impact has changed, but the rate of disorder hasn't. What about the treatments? Aren't they a bit iffy? That's what I get asked. They're really well tested. I trained as a doctor. Surely they're not as well tested as some of the other things used in medicine. Well, this is a body that all doctors in the UK, we try and abide to what's called the National Institute for Health and Clinical Excellence guidelines when you're treating. And actually ADHD, there's enough research and enough treatment trials that there is a nice guidance on ADHD. I was talking to students earlier, and actually some of the treatment studies for ADHD, there's been more of them than they have been, and better quality than they have been for many medical conditions. So what does NICE tell us? Well, in the UK and Europe, for those who've got very severe ADHD, start with medication and use behavioural treatment. If you're at the milder end, you start with behaviour treatment. If that doesn't work, then you put in medication. And for adults, medication and ways of thinking, what we call cognitive behavioural therapy. There's trials that suggest that seems to help. And then you've got the other things where on their own they don't have a big effect, but they're general things that you should do. Support in school, really important. Education, really important. Work support for older individuals. Lifestyle management, that's true for any chronic disorder. Eating well, sleeping well. These things are important for any chronic disorder management. For ADHD, artificial food colours and essential fatty acid supplementations, there's not been as many trials here, but basically overall it seems that they're weak effects, so it's worth improving diet, but for children who are at the top end who've got a diagnosis of ADHD on their own, they're unlikely to help enough. So what about medication? What does medication do? We want to reserve medication for those at the extreme end. Why? Well, we do that across the whole of medicine. Any medication has the potential for side effects, so you do not want to use it unless the person is really having serious problems. However, if they're having serious problems, there's harms if you don't help them either. So you always have to do this balance. So this is for the most severe group. So what does medication do? We know of loads and loads of treatment trials now showing stimulants work. These have been around since the 1950s. One of the students was asking me, aren't these really dangerous? Well, yes, any medication potentially you don't want to take it. You certainly don't really want your child, unless they have to take it. But it has been around since the 1950s. So compared with many other medications used in medicine, I think I'm always less worried about this compared with lots of the newer medications. Atomoxetine is a new medication that's also been shown to be effective. How do these stimulants work? Well, here's the science bit. This is a nerve cell, this is another one. And how do nerve impulses, for those of you in sixth form, you'll be knowing this from biology, that you get nerve impulses transmitted across what's called a synapse through chemical transmitters. One of these transmitters in the brain is called dopamine, and stimulants increase dopamine availability. That's been shown in imaging studies. This medication works differently. It works on another different type of brain transmitter and increases what's called noradrenaline, another signal here, increasing impulses. What does it do? Well, as I said, been really good evidence showing that it reduces overactivity and concentration. Now, but it's not doesn't do that just in those with ADHD, so you can't use it as a test. Oh, if that works, they've got ADHD. I mean, you wouldn't dream of doing that for blood pressure. Oh, if your blood pressure goes down with that, you've got high blood pressure. Now, I haven't got high blood pressure. If I took an anti-hypertension drug, my blood pressure would go down. It's just shifting things. Now, if you've got a problem, that makes a big difference, but you don't want to be taking it if you haven't. The benefits are there. That's been shown. But what is sad is that the benefits in these treatment trials show that they're short-term. Longer term, there's lots more complications. It doesn't seem to work, not in terms of side effects, but it just doesn't seem to be having the same benefits as people get older. We don't know why that is, whether it's some change in the brain or whether the social environment changing. And we want to reserve it for the most severely affected. So the other thing I get asked, well, I work with children. So, do children grow out of it? They change. I mean, anyone who knows children, has children, know they change. So yes, some children with ADHD do better as they get older. You know, you hear children leave school and find a niche and things are a bit better. But we also know that whilst the overactivity, you don't see the running around once people reach the teenage years and that, they do still feel that inside. This is what people call a subjective feeling of restlessness. And the concentration problems remain. So there's still this lag from what we call typically developing individuals. So everyone's concentration tends to improve as they get older, tend to move less. I've noticed that as I get older. that's just normal, but the ADHD kids just show that difference from everyone else. Many don't do well, however. Some get a new mental health disorder. It's stressful having ADHD, they get depression. We know it affects educational attainment. It just does. Relative to what you would expect for someone's intelligence, they don't do quite so well. Obviously, if they're very, very bright, they might still do quite well, but not as well perhaps as other members in their family. It affects social relationships, being able to make friends. And at worst, it increases risks. Having road traffic accidents, getting into criminal behaviour, misusing drugs and alcohol. And some of this people think might be self-medication, but some of it is just because of failing at school, perhaps being excluded, dropping out, not having friends, not being able to mix with children who aren't having these problems, and turning to these other sort of risky behaviours. So, this isn't to show a picture of myself. I'm going to show you a video clip of that's not very flattering, actually, if I'd wanted to show you a picture of myself. I want to show you a clip of a family who very kindly agreed to come in. They specifically to be filmed for this. And this is a 14-year-old girl who basically she was picked up in primary school and she had major problems in primary school. She's done better in comp. She has had medication, so you'll see her. She's come in, she's had medication, so you won't see her moving about. The family have other children. They have 2 older daughters. One is in university. They're very caring. They've adapted around her. She doesn't have friends, but they've adapted. She spends time with the parents. The parents do things with her. She's 14. She's not seeing friends, unlike her sisters who are, going to parties, mixing, doing various things. She's not. And so I think they've managed very well. And, of course they've come along to agree to be filmed. But I thought it'd be interesting, rather than just me talking, to actually see someone and a real person and get something a little different. What was daily life like? I mean, you mentioned, a little bit about what was she like at home?
Her concentration was so poor,
Yeah.
so reading skills were not up to the level they should be, and things like that, because she just, no matter how much we tried, we couldn't get her to sit down just to read a simple book.
Okay.
She was very, fidgety, very constantly.
Was that a problem at home as well as at school?
Yeah.
What sort of ways did it cause difficulties for her, did you notice?
I said homework, things like that. She couldn't do any homework.
Yeah.
She never, play-wise, she never stuck to it. Like, she'd be flighty. She'd have 2 minutes for one thing. She'd be like, it's enough now. Go out. It never captured, nothing ever captured her attention long enough to keep her. We had 2 perfectly well-behaved children, and we had Shannon, which was off the walls, we didn't know how to cope with her. We did once take her out to a restaurant that didn't have any play equipment and things, and I was so frustrated that I just paid off through the meal. I paid. I said, oh, come on, God, we'll just take him home. I can't, because there was no way that I could actually sit down and enjoy a meal, because I was constantly going to bring her back, because she was running in between the tables, and you'd your parents saying, oh, look at her, why can't she control her children and whatever, How many times I felt like screaming at them, well, look, she can't help it.
I keep forgetting where I put stuff. I always misplace stuff.
Yeah.
And then once I get a rethink of it, like say now, I just bought a new biology book. Tomorrow I could find my old biology book.
Okay. Right, so I've dealt with the first issue that I said I would deal with. What is ADHD? I'm going to move on to something different now. What do we know about the causes of ADHD? And as Kate said, we did quite a lot of that type of research here in Cardiff. So, I said I would talk about myths. Well, the first myth is there's such a thing as the cause. Now, if I move this bottle, I have caused it to move. It just doesn't work like that in medicine. The most common disorders in ADHD is a typical medical common disorder. You've got lots of different causes. There isn't just one thing. There are a few rare diseases where you've just got one thing. Down syndrome is one. They're called rare diseases. They're not typically something that's flooding through GPs' doors. Most common medical disorders, diabetes, high blood pressure, heart disease, ADHD, autism. There are lots of different causes, genes, environment, and chance. So there isn't the cause. The other myth is cause means it will happen, like moving this bottle back here. And it doesn't. It doesn't mean it will happen. Now, I'm sure there are some very good chefs here in the audience, and well, we've just had Christmas. I'm probably this person who's not a very good chef. We all know that you can have a recipe, you can follow it, but there's absolutely no way necessarily it's going to come out like that. Certainly when I'm doing it, it doesn't come out like that. Yeah, DNA's like that. Yeah, you've got a recipe. You've got a recipe for a chocolate cake. You're not suddenly going to get an orange cake generally, but there's a long way between that and that. So it just means that, just to remember, genes are probabilistic. Not just for ADHD, for everything. It's not just genes. It's the way risk factors work in medicine. Risk factors have probable effects for the majority of health conditions. Everyone knows cigarette smoking increases the risk. It's a really powerful risk, one of the most powerful risks we have in medicine. Heart disease, lung cancer, it's not even debated. It's a huge effect. Most things in medicine aren't that big effect. But we still know not everyone who smokes gets lung cancer or has a heart attack. And not everyone who has lung cancer or who has a heart attack has smoked. So that is just also true of other medical conditions, and ADHD is no exception. And there's a lot of misunderstanding about risk and cause, and I hope I've explained some things about it. So, with that in mind, let me turn to the research on genetics and ADHD. One of the students earlier asked me, how come you got interested in ADHD? And how come the genetics? Well, I was driven by the research findings. There was no personal reason, actually, for being interested in ADHD. I was interested in children's disorders. I've seen it clinically, but you have to see what was there. Now, when I first started, we didn't know, really, that there was any genetic contribution to ADHD, but that then started... we started getting evidence. So there's ways you can look at relatives, families, and actually people who have got a relative with ADHD, you're about 5 to 9 times more likely to have ADHD if you've got what's called a first degree relative, like a brother or a mother or father, of having ADHD yourself. You don't get it, it's there from the beginning, it's not like an infection. Which is about the same, similar to rheumatoid arthritis. Is it something about families? That's what people say. Well, no, because even if you've got a family member with ADHD and you're adopted away at birth, you still show increased risks of ADHD. And the risk is greater for those who are more closely related. So when all that evidence came out and we did studies, I started to get more interested. And then we did work on twins, genetically identical twins and non-identical twins. And what we found is ADHD is really, really highly heritable. Similarly to autism, schizophrenia, depression, just to show that not everything is in the field I work in. Depression, anxiety weren't very. And that's how I got interested in the genetics. And studies across the world, just UK, New Zealand, Australia, Norway. However, just to say the point again, because I get a lot of flack for this, you'll notice I keep saying it. No common medical condition is entirely explained by genes. These are identical twins. Anyone who knows identical twins, even though they come from the same egg and therefore are genetically identical, they aren't identical. You've still got environmental experiences, and for an early life disorder, intrauterine life is important, and you've got chance, things that just happen. We don't know why they do. So, given it's so highly heritable, like autism, it's unsurprising there's lots of us in the world, Cardiff is one centre. We work with people in lots of centres in the world. I'd like to think in Wales that we are doing very well, and I think we've had a lot of support from families in Wales. So how do you go about identifying genes? Well, it's quite straightforward. People say, oh gosh, you must be really clever doing genetics. I thought, oh no, not really. Take a bunch of people with ADHD. You need very large samples to do this type of study. And you get people who haven't got ADHD. You could do this with diabetes, same sort of thing. Heart disease. Get their DNA. You define the genetic variation, and I'm going to talk about how we define it, and that's what's changed, the way we define it, and compare them. And you look whether certain patterns are more common in the ADHD group than the ones who haven't got ADHD. That's putting it simply. For those of you who are scientists, forgive me for a simplistic explanation of genetics. So I said you have to define DNA variation, and we've got lots of ways of doing it. For those of you who've done biology, you'll know that DNA consists of these, you have a sequence of nucleotides, and there's certain places in our genome where we're all different. Yeah, we call that and they're common, and we call that common gene variation. And because it's a single change, we call them single nucleotide. That's that code. Variation, SNP, single nucleotide polymorphism. And we look for differences between those with ADHD and those without. Now, one of these SNPs, on their own, which is found to be more common in ADHD than people who don't have ADHD, on its own, it's got a really small effect. It's not going to ever be enough to give you ADHD. Lots of them together, though, we found, do contribute ADHD risk. And we've done quite a lot of work now showing that, and which has actually been replicated across studies, and I think it's quite pleasing that here in Wales, might be a small country, but we did show this and went to a meeting, and our American colleagues have found something similar. We also found, this is work done by Joanna, who's a PhD student who works with me, that the ADHD genetic risk, do you remember I told you there's lots of different types of neurodevelopmental difficulties that go together? The same genetic risks seem to affect learning ability and language, particularly the social type of communication, you know, being able to read what people are really meaning, being able to kind of do the kind of nuances of a smooth social interaction. It seems to affect those sorts of difficulties as well. That's one type of class of genetic variation. There's a second one, which people have got very interested in, which is that we vary in terms of, like, all of us have little chunks of DNA missing or extra. If you've got little bits, that's just fine. When you've got bigger bits and you've got whole chunks of DNA in your genes missing, that can result in problems. And these little these bigger deletions or duplications, or smaller deletions or duplications, are known as copy number variants. I'm going to call them CNV for short. Geneticists we love saying things for short, and we go around pretending we're very clever. It's just actually another language, CNVs. And they're actually just a bit of extra chunk of DNA or missing DNA. And they've been implicated in a lot of brain disorders, children with intellectual disability, autism, schizophrenia, epilepsy. They seem to have more of this missing or extra DNA. So, we also looked in ADHD. Now, Kate and I weren't terribly surprised, but some people were. It was published in The Lancet. We found that children with ADHD who didn't have autism, and even the ones who didn't have intellectual disability, even though they go together, we screened for them, showed an increased rate of these CNVs, deletions and duplications. And the regions in the chromosomes, what they were, seemed to overlap with autism, even though they didn't have autism. And because the types, for example, mood disorders don't have these sorts of what we call genetic variations, what really seemed to show particularly these types of genetic variations are the neurodevelopmental disorders. And it really highlighted ADHD as what we call a neurodevelopmental disorder, a development of the brain. Something has changed. And actually, the new classification system puts ADHD with autism and all the other learning and communication problems as a neurodevelopmental disorder. So I said it was published in The Lancet, and it created a lot of media interest. Kate knows me well. We were quite sort of shocked that there was so much interest. Some of it was very positive from families, others was really very hostile. But it's what we found. We didn't have particular wishes or to find or not find, it's what we found. So, why is this interesting? It gives us a few biological clues. We know nothing. The brain is pretty inaccessible. And unlike my colleagues who work, say, on the pancreas, you can't just sort of pick out a bit of tissue. It suggested that genes involved in brain development were involved. I talked about those transmitters which were involved in nerve impulses. This is one, nicotinic acetylcholine. It's a chemical brain transmitter that seemed to be involved. Another brain transmitter, glutamate's an excitatory chemical brain transmitter, that seemed to be involved. Lipid pathways, cholesterol, things that we hadn't really thought about. So, do genes contribute to ADHD? I started off completely agnostic at the beginning of my career. I'm afraid the evidence suggests they do. And the evidence isn't just one, it's lots of studies. Lots and lots from all over the world. So does that mean we can do gene testing? People come into our clinic, take blood? No. Why? Because, as I said, it's not a single gene disorder. It's not like Down's. It's like most medical conditions. Not everyone who has the risk, that one particular genetic risk, has ADHD, and not everyone with ADHD necessarily carries that risk. You can't use it for testing. So why are we doing genetic studies? Well, it helps our understanding. You know, people have these issues about, well, you know, if you've got a child with ADHD, and I see people in clinic, you want to try and understand more about what's caused it. You know, a lot of families think, oh, I've caused it. You know, well, this helps understanding. It gives, as I said, for brain disorders, we really don't know much about biology. It used to be the case for sort of disease like diabetes. We do now, but we don't. It gives you some clues about biology which can help to get new treatments, new medications for the most severely affected, but clues on other treatments as well, not just medications. So this is another myth. Genes mean only medication works. No. Genes mean ADHD can't be changed. No. And I'm just going to say, I'm going to give you an illustration, this is actually work done by Kate, about how genes could give clues about new treatments that aren't necessarily always drugs. So, this is work we did a few years ago. We were interested in gene variants that were going to predicting a very serious form of ADHD, which is characterised by particularly strong behavioural disturbance. And we were interested in an enzyme called catechol-O-methyltransferase. As I said, we like acronyms, called COMT. It's an enzyme which is basically a bit like a hoover. It clears up this brain chemical called dopamine, and especially important in the front part of the brain because it's the only way that this gets cleared. And this front bit of the brain, called the prefrontal cortex, is very important for planning and control. And there's a gene variation that affects how fast, if you like, how effective and hoover this enzyme is. Some people have a fast version, just sort of mops up the dopamine here very quickly. Others have a slow. So some people have the high activity, gets rid of the dopamine very quickly, and that seemed to be linked with planning and control problems. So we looked at it in relation to a severe subform of ADHD. What we found, this was several years ago now, that people with the very fast version of the enzyme, that gene, they seem to have the more severe disturbance. And that's been replicated in New Zealand, London, and in the States. People have put the studies together, that comes out quite clearly. Now that's all very well, but what Kate and I were interested in was how do you get from this gene, you can't change someone's gene, and as I said, there's lots of genes, to here. What clues might we get? Well, we knew from colleagues who work in brain science that this enzyme was involved in planning and control, which I said, called executive function, for those interested in psychology. But it also, brain imaging studies suggest it also influenced emotional understanding, sort of form of communication. So we tested whether this went to here via this or via this. Now this gene was associated with that and that, but what we found is the route to here was through the emotional understanding. Now, emotional understanding is not something most people don't treat it in ADHD. We haven't even thought about interventions for that. So it's just an example how genes can actually tell you a little bit about pathway and give you clues all along the way from biology to psychology. I like balance. And as I've said, nothing in medicine, hardly, the common diseases, is entirely genetic. There is evidence that environmental factors contribute. Which ones? Well, it's early. It's got to happen early. All this is there in the early years. So, particularly interested in environment that children experience in the womb or at birth, or very early on in life, including toxins. So, a few years ago, we looked, and other people looked at lots of early life factors, with maternal smoking and pregnancy. Lots of studies suggesting mums who smoked in pregnancy, children later had more ADHD. In fact, this is Kate and me. Put all the studies together in the world. That's, for those who are mathematicians or statisticians, that's an odds ratio of 2.4. That's quite a big effect size. Maternal stress and anxiety, low birth weight and being preterm, lead exposure. These were the kind of best candidates. So Kate and I were really interested in smoking and pregnancy, and this is the beauty of science. So we wrote lots of papers about maternal smoking and pregnancy. In fact, we wrote a whole project looking at maternal smoking and pregnancy. But as a scientist, you have to attempt to try and disprove your hypothesis. You have to think of other explanations. And as I said, we started off believing smoking and pregnancy is important, but we were conscious of something really important. It's not random, mother smoking in pregnancy. Most people know it's bad. So these are the people who continued smoking in pregnancy who really could not give up. We know that not being able to give up when you really should, that's got a very strong genetic component to it. So yes, it could be maternal smoking in pregnancy, the nicotine, the carbon monoxide, the altered placental blood flow, and that's what's resulting in ADHD. But it could be that genes that are influencing mothers not being able to stop smoking are also being passed on to her child and showing as ADHD, because we know genes affect lots of different types of behaviours and conditions. What we really would like to do is remove that so we can test that. How do we do that? Well, it's impossible with animal studies, people who work with animals, and we don't. You can take rats or mice and sort of remove them sort of in uterine life and move them to an unrelated mother to finish the pregnancy. How can you do that in humans? To adopt away in the womb. You can't do that, we don't work with animals. We thought, right, actually we have got a natural experiment, so to speak. We've got children who are related and unrelated to their mother via IVF treatment. If smoking in pregnancy really has risk effects on ADHD by, for example, carbon monoxide or nicotine, it won't matter whether the child is related or unrelated to the woman undergoing the pregnancy. You'll still see the same link. What did we find? We found that smoking in pregnancy didn't matter whether the mother was related or unrelated, it lowered birth weight. It's not a good thing to be doing for child health. Nothing with ADHD, they were unrelated. Same with stress in pregnancy. Stress in pregnancy, harder to control, but babies who were exposed to more stress had lower birth weight and prematurity, regardless of whether they were genetically related. Just doesn't seem a very good thing. But nothing for ADHD once you remove the genetic link. Okay, so smoking in pregnancy we now think doesn't actually cause ADHD. So let's think about life after birth. There's lots of myths here. Bounds with it. ADHD caused by families? Why? Well, actually, we know that childhood antisocial behaviour, parenting, negative parenting, sort of stressful family relationships, and poverty, there's been quite a lot of experiments and treatments showing that it does affect antisocial behaviour. So what about ADHD? Keep an open mind. There's been lots of studies now, treatment studies, follow-up studies looking at the direction of effects, and it isn't like antisocial behaviour. What people have found is that it goes this way, that the ADHD child's symptoms result in the negative relationships. You treat it and the relationships improve. Okay? It's not actually exactly the same as antisocial behaviour, on lots of reasons, but this is one. So, environmental risks are important. We don't have firm evidence on what they are. We need much more work because it's still quite elusive. Am I saying, people will ask me, perhaps, lifestyle, family, better parenting, social environment are irrelevant? Well, of course they're not. We know that they're important for normal development. Optimising those is good. They're important for medical disorders. If you've got diabetes and your social environment's really stressful, that ain't good. Diabetes, asthma, infection. Even if they're not causes, and they don't seem to be causes for ADHD, they could still modify the cause. They're not sensible to ignore, that's common sense. But I'm just saying they're not been found to cause ADHD. So, to sum up, what have we learnt from science? So rather than trusting to opinion, ADHD isn't new, but the recognition rates have changed. There isn't a test, so it needs really careful assessment. And I do think sometimes that is one of the problems. It falls into disrepute because you're reliant on very good practice. There is treatment there. We don't have treatments for lots of things. We don't have treatment for autism. It works in the short term. Longer term, it's more difficult. Children develop, brains change, and social and educational circumstances change. I mean, children will have to make the transition into comprehensive school. They reach the teenage years. It's got much more different challenges. You've got educational challenges, you've got social challenges, romantic relationships, friends, sleepovers, alcohol. They change, so there are different demands. So somebody who could be doing not too badly at one time point could do a bit better. The girl I showed you actually was doing badly in primary school and things got a bit better. So it does make sense to try and reduce the stress of negative impacts and complications of having ADHD, the secondary fallout, if you like, as far as is possible, and optimising the environment. There's ADHD misunderstandings, I hope I've shown you, it's not the same as antisocial behaviour. Why? ADHD levels in the general population have stayed steady over time. Antisocial behaviour in young people in the latter part of the 20th century got shot up. The genes associated with ADHD, the brain changes aren't the same as antisocial behaviour. Parenting and poverty are important. They have been shown to have a causal risk effect on antisocial behaviour. That hasn't been found for ADHD. Not saying they don't matter. They are. That's a important social phenomenon. Of course they do for any child, but they just haven't been found to cause for ADHD, and ADHD is not the same as antisocial behaviour. Causes, I just hope I've highlighted, there are multiple risks. Isn't a single cause. It's strongly genetic, but you can't use genes to test. We might not like it. I started off not particularly liking genetics. There were lots of things I started off liking, but we found genes to contribute. I had to get interested in genetics because they've been found to contribute. And we've also demonstrated that ADHD is very closely related to the other neurodevelopmental disorders. It's one of a family. Environment, those early environment factors, we do need more really solid work, more science on causes and what modifies the course of it. You're getting more recognition that ADHD can carry on into adult life. How can you modify the course? I want to end with something about the history of medicine. We've got a few people who are aspiring to do medicine. If you go back and look at history, and I think there's at least one GP here in the audience, people used to treat many disorders with bloodletting, leeches. Don't get that in your average GP surgery now, at least not to my best knowledge. It was the last century that people said autism was due to refrigerator parents. People were horrified who said that now, but it's there. It's in the literature. Not very long ago in my lifetime. Epilepsy. Ancient Greeks thought it was something to do with displeasing moon gods. A lot of people thought it was possession by demons. I just want to highlight that it's really important science, really, really, really important science in dispelling these myths. We want a situation where it's not just opinions driven by science. But at the same time, for those young people who are also aspiring to do medicine, we want to bridge the science with actually having the human touch, because these are real people affected and real families, and to remember that. And I'm really hoping that the science will have an impact on the person. And I'd just like to end by thanking the audience for their attention at this time of night, and for my research funders. I have no conflicts of interest. I do sometimes get asked that. I have no links with pharmaceutical companies. I haven't done all this work on my own. I've worked with a wonderful team of people who work in the lab, psychologists, statisticians, and I'm particularly grateful. We've been very lucky in Wales. We've had families who've participated in research, great NHS colleagues, and I'd like to thank you very much.